The OMT protocol begins with soft tissue to the thoracic and upper lumbar paraspinal muscles. Depending on the hospital room setup, the treating physician sits or stands at the side of the bed and places his or her hands under the patient's back with one bed sheet between the hands and the patient's body. The physician locates the spinous processes of the upper thoracic cage or the lumbosacral junction with his or her fingertips, and then moves the fingertips laterally to the medial portion of the erector spinae muscles. The fingers curl to press into the medial portion of the erector spinae muscles, then pull the paraspinal muscles laterally to stretch and knead them by massaging. This technique is performed to all of the patient's thoracic and upper lumbar paraspinal muscles. More attention should be given to an area of muscle tightness or spasm. The physician may also use paraspinal muscle inhibition or direct sustained pressure to these areas. This technique is repeated on the patient's other side. The duration of the technique should be about 1 minute. The second technique is rib raising. To perform this technique, the treating physician sits or stands at the side of the hospital bed and places her or his hands under the patient's thorax, again with one bed sheet between the hands and the patient's body, contacting the rib angles with the pads of his or her fingers. With fingers flexed, the physician applies traction to the rib angles, pulling them laterally. While traction is maintained and the physician's wrist kept straight, the physician's elbows descend towards the floor while their hands move the rib cage anteriorly. This motion is repeated several times until rib motion is improved or there is greater ease in performing the technique. The physician's hands are then moved to an adjacent set of ribs, and the procedure is repeated until all the ribs on one side are treated. Restricted areas are treated more intensely to promote normal rib cage motion. The technique is then repeated on the patient's other side. The approximate duration for performing this technique is 2 minutes. To promote time efficiency, the soft tissue to the thoracic and upper lumbar paraspinal muscles and rib raising can be performed sequentially on one side of the patient before treating the patient's other side. The third technique is an indirect myofascial technique to dome the diaphragm or improve diaphragmatic motion. From the side of the patient's bed, the treating physician places one hand under the patient where the diaphragmatic muscles attach to the lower ribs and vertebrae, and places the other hand on the abdominal epigastric area. The physician's hands then are rotated in opposite directions to determine the direction of greatest freedom of movement. Tissues are then moved in the direction of greatest freedom to a point of balance and are held there until a release of tissue tension is palpated. This technique generally takes no more than 1 minute. The fourth technique is soft tissue to the cervical spine. From the head of the patient's bed, the treating physician places his or her hands on the patient's cervical paraspinal muscles and applies soft tissue kneading and stretching. The approximate duration of this technique is 1 minute. The fifth technique is suboccipital inhibition. From the head of the patient's bed, the treating physician places her or his fingertips on the suboccipital muscles and at the base of the patient's head. Steady, gentle outward or lateral and cephalad traction is applied to achieve a relaxation of tissue tension. This technique should take approximately 1 minute. The sixth technique is myofascial release to the thoracic inlet. From the head of the patient's bed, the treating physician places his or her hands with the thumbs lying posteriorly over the transverse processes of the first thoracic segment and the fingers lying anteriorly on the clavicles and the first two ribs. Passive motion testing is performed to determine the direction in which tissues move most freely in the coronal and horizontal planes. The tissues are maintained in a position of ease until a release or softening of tissues is palpated. If restriction is still palpated after the technique is completed, then the tissues are taken into the barrier direction of bind until a release is palpated. This technique should take approximately 1 minute. The seventh technique is thoracic lymphatic pump with activation. From the head of the bed, the treating physician places her or his hands on the patient's anterior superior portion of the rib cage with the thenar eminences of each hand over the pectoralis muscles just below the clavicles. The physician's fingers are spread and angled towards the sides of the patient's body. The patient is asked to take a deep breath and exhale. During exhalation, the physician applies a rapid alternating pressure on the chest wall at an approximate rate of 120 compression-relaxation cycles per minute, producing a rhythmic pumping action. At the end of exhalation, some pressure is maintained on the chest wall while the patient inhales again. The pressure on the patient's chest cage will be increased with each successive exhalation and is sustained with the subsequent inhalation, beginning with the second or third inhalation. During the first 1/3 to 1/2 of the inhalation, the physician briskly removes her or his hands from the patient's rib cage. This movement causes a sudden release of buildup of pressure on the chest wall and causes the rib cage to rapidly expand, creating a sudden increase in negative intrathoracic pressure and causes air to rush into the lungs. This technique is repeated continuously for approximately 2 minutes. The eighth and final technique in the standardized portion of the OMT protocol is the pedal lymphatic pump. The treating physician stands at the foot of the patient's bed, gently and rhythmically dorsiflexing the patient's feet, causing the abdominal contents to intermittently push or slosh up against the abdominal diaphragm. In the case of a patient who has a lower limb amputation, the physician places a hand on each leg at the level just above the amputation site. The physician then rhythmically and repetitively pushes the leg's cephalad and then relaxes in a smooth and coordinated fashion. This technique should take approximately 1 minute. These 8 standardized techniques were ordered to optimize potential benefit from OMT. By following these steps, patients are first relaxed. Second, rib cage restrictions are relieved to improve depth of respiration and to minimize maladaptive sympathetic reflexes, which could be hampering the immune response to the mnemonic process. Third, musculoskeletal factors that may be causing maladaptive parasympathetic responses to the mnemonic process are alleviated. Finally, circulatory and lymphatic flow is augmented within the lung parenchyma and rib cage.